Today, I'd like to talk about abnormal liver tests and how to get the most information you can out of them. So we're going to go over what do they mean, some of the quirks and exceptions, and try and come up with a sensible approach to evaluating the liver from a laboratory point of view. So I'm going to start with a case. This is a 16-year-old who noticed that she was icteric. You have some local labs. The transaminases were 2,300 and 1,600. The Billy was 4, and they said that they had a negative acute hepatitis panel. So she's got high transaminases. What does that mean? Transaminases are enzymes that are inside a liver cell. And if you lyse the cell membrane, they can get out and into the bloodstream. So they're really liver cell death tests that tell you that the liver cells are breaking down. So what is the differential for really high transaminases? It's actually pretty limited. It includes acute viruses, ischemia. So if you either are hypotensive, have an arrest, for some reason don't get good blood flow to the liver, you can get this. Drugs and toxins can do this, and autoimmune hepatitis can do it as well. So what is an acute hepatitis evaluation? It may not be what's in EPIC. So EBV is certainly one of the considerations. And for this, you can get titers of the various antigens, you can get IgM, you can get PCR. We tend to only follow PCR in immune suppressed kids because we don't really know what to do with different levels in the normal population, and their PCR may be positive for a long time after it's not really that virus that is causing the issue. CMV is another common cause of acute viral hepatitis in kids. We can get IgM, and again, we can get PCR. If you're looking for hepatitis A, you have to be really careful what you ask for. Sometimes you're going to get total antibody, and this includes both IgG and IgM. And if they've been vaccinated, it's going to be positive. If you want to know if their jaundice right now is from their hepatitis A, you need to get the IgM. Of note, this is a really good vaccine, and so if you have documentation that they received it, it's probably not hepatitis A. There are other viral hepatitises that are actually really common, things like adenovirus, enterovirus, other viruses. If you're looking for hepatitis B, you need surface antigen. And if you're looking for acute hepatitis C, you need to check the RNA. The antibody isn't going to be positive for weeks to months. And so having a negative hepatitis C antibody in the face of acute infection doesn't really tell you anything. Okay. Next case. This is actually two cases with very similar results. It's two babies. They both have pale stools. They both have elevated transaminases. They both have the same total and direct bilirubin. One has a GGT of 560 and one has a GGT of 11. Both of these are very probable and common sets of liver tests, and the difference in GGT should send you down different paths. Let me explain why. So bilirubin and bile flow are completely different processes. They usually go together, so we use bilirubin as a surrogate marker for bile flow, but that's really all it is a surrogate marker. They go through different sets of transporters. So as far as bile is concerned, it is made in the hepatocyte under genetic control, and then it is transported to the lumen membrane, and then actively transported into the lumen, and then a lot of different processes like CFTR add some fluid to the bile, and it's transported down into the gut. So that is one set of mechanisms. We make bilirubin from broken down blood, and neonates have a huge load of blood that they need to get rid of because they go from a hypoxic environment to one that's oxygen rich, and so their hemoglobin goes down. It gets turned to bilirubin, goes to the liver, it's conjugated, and then the rate limiting step is transport of bilirubin into the bile duct. The bile acids then wash it away. I always try to explain it like if you had a stream in the fall, the water is the bile acids, and the leaves that are floating on top of the stream are the bilirubin. If you don't have very much water, it's going to get clogged up. And so sometimes not having good bile flow can clog things up. Then we get to GGT. So GGT is a protein that's located in the bile duct enzyme, and it just kind of hangs down into the lumen. Bile is a detergent. That's why it's so good at helping us absorb fat, is because it breaks things down. It also breaks protein down. So if you have a lot of bile acids sitting in your bile duct, not going anywhere, they're going to dissolve off the GGT and it's going to go up in your serum. So you need to have bile acids to get an elevated GGT. So what are the reasons for low GGT? One, maybe you can't make them. Maybe you have a genetic synthetic defect. These are actually rare, but they certainly happen. Premature infants don't make very many bile acids just because they're premature and those enzymes haven't developmentally achieved their regular levels yet. And so they may not mount a GGT response. And then probably the more common thing that we worry about is that you have a genetic issue where you make bile acids, but you can't transport them out of the liver cell. So the baby with a high GGT is somebody I would really need to worry about something like biliary atresia or alpha-1. They're getting the bile acids out of the liver cell and they're hanging out in the bile duct. The other baby probably either has something called PFIC or progressive familial intrahepatic cholestasis, which are genetic defects in bile acid transport, or a bile acid synthetic defect. And by making the recognition between those two things, you can really expedite your workup because you don't need to go at it from both ways. All right, next, we have another 6-week-old. this baby comes for jaundice, transaminases are normal, GGT is normal, and the total and direct bilirubin are elevated. So what does this tell us? So back to the drawing. This baby actually has a UTI, and bacterial infections inhibit bile acid uptake, but most importantly, they inhibit the transport of bilirubin. And so you're conjugating the bilirubin just fine, but you can't transport it into the bile duct. And so you get this buildup of bilirubin that then back diffuses into the liver cells. So it is something that's pretty important to recognize. I think you all know that sometimes people with sepsis get jaundice. This is the same mechanism. It's just really obvious in babies because they have such a high bilirubin load to process. So we've talked about GGT, we've talked about bilirubin and transaminases. Now it's time to think about the synthetic function of the liver, or how it makes things. Included in that would be coags, albumin, cholesterol, glucose, and bilirubin. Bilirubin in that you need to be able to conjugate it. You also need to filter things through the liver. There is a reason why the liver is between the gut and the heart. It's to filter metabolites and food after digestion. It's also really important for metabolizing drugs. It has a dual blood supply in that most of it comes from the portal vein, but some from the artery. You can actually monitor school performance as a way of somebody with chronic liver disease. They get subtle changes in how they're able to do math and things like that, which you can pick up on neuropsych testing, but just asking them what their grades are. You know, you may have someone who got A's and B's and now they're suddenly getting D's and F's. And in talking to them, they seem like they're okay, but they really have some low-grade encephalopathy. These are just kind of a bonus point quirks type thing. So this is a set of labs from one of my patients, and there are a couple of things to notice that we look at. One is the total protein, which is a combination of albumin and IgG. So if you're worried about somebody with autoimmune hepatitis, they usually have a high IgG, and you're going to get the total protein back way before you get the IgG back. The other thing on this patient is she has a really high cholesterol, and that's because cholesterol is synthesized in the liver and excreted down the bile ducts. And this girl had autoimmune hepatitis and some cholestasis and poor bile flow. So she was not excreting her cholesterol very well and got high levels of it. Now, if this same patient had a cholesterol of 45, it would be a really good marker of synthetic function because she's losing her ability to make cholesterol. It's something that often you have the lab result for, but you don't really think about it being helpful. Just some other kind of odds and ends. Don't forget that muscle is a source of transaminases. And so somebody with, say, muscular dystrophy or muscle injury, or even a football player who's working out too much can have high transaminases. You need to fractionate the bilirubin to tell if it's hemolysis or really a liver problem. I also wanted to point out there's a website that if you Google liver tox, it's by the NIH, and you can look up most drugs and it will tell you what their liver toxicity is, give you references, give you expected courses and examples, and it's incredibly helpful. I also wanted to put in a plug for being fiscally responsible. CMP is something that's mandated by the government, and it's 30% the cost of a hepatic function panel. At Children's, if the bilirubin is abnormal, they will automatically fractionate it for you, but that's something that we have put into place here and isn't true at most places, so be careful. Nationally, usually a CMP doesn't have a fractionated bilirubin. Kind of the other little tidbit is that you need zinc to make alk phos. So if you have chronic diarrhea and zinc deficiency, your alk phos may not go up. So it may be a reason for low alk phos, or you may not be able to rely on your alk phos as a good measure of bile ducts. So with that caveat, another case. This is a 12-year-old with icterus during a viral illness. The pediatrician got some transaminases. They're normal. The alk phos is normal. The GGT is normal. And the bilirubin is elevated. And so they're coming to you absolutely frantic because they are sure they have bad liver disease. If you fractionate it, you will see that it's all indirect. And this is a case of Gilbert's, which is a functional deficiency of gluconeotransferase. It is not a problem. And whenever the patient gets stress that causes a high heme load, so viral illness, exercise, fasting, that will push more bilirubin through the system, which the liver can't conjugate, and so the direct goes up. This usually shows up after puberty, just because the sex hormones make it a little bit more obvious. But these kids are always going to have elevated indirect bili. You don't need to follow it. You do need to make sure that they don't have heme disease that's causing the hemolysis, and then just make sure that they know that their total bilirubin is always going to be elevated. So if somebody's worried about their liver, they need to make sure that it gets fractionated. Next is another patient of mine. This kiddo had abnormal transaminases. Alk phos was okay, GGT was really low, and he had a very low GGT. I was seeing him because he kept falling down, and he had a big liver. And the combination of the really low GGT and the unmeasurable vitamin D made me think that he probably didn't have bile acids to help him absorb his D and to send his GGT up. So I sent a urine bile acids, and he had a bile acid synthetic defect. Next patient is a 4-year-old who seemed pretty healthy. His transaminases were persistently abnormal, and everything else was okay. This GGT was a little lowish, although normal, and so we did look for bile acid issues and didn't find any. and then sent a CK, and he actually had Duchenne's muscular dystrophy. And then next patient is a 6-month-old with Hep C exposure. Liver tests are normal, and the pediatrician got a hepatitis C antibody, and the family is really upset because mom thinks she gave her baby hepatitis C. You need to remember that you get transplacental passage of hepatitis C antibody, and so you can't use that as a measure until they're 18 months of age, and before then you have to get RNA. This baby actually did not have hepatitis C, and we were able to calm things down, and the parents were certainly very happy. Next patient, and this is the last one. This is somebody who has an AST of 350 with an ALT of 150. L class is low. GGT is a little high. The coags are very prolonged. The kiddo has half direct and half indirect bilirubin, and the kiddo is anemic. So in kind of putting this together, the AST higher than ALT would go along with hemolysis being part of this, as would the low hemoglobin and the bili that's kind of half direct and half indirect. The low alk phos is also a clue. And this is someone with acute liver failure from Wilson's disease that is caused by a sudden release of copper into the blood that causes hemolysis, and they very quickly go into liver failure. I put this on here because it's something that you can't afford to miss, because this child needs a liver transplant very quickly, or they'll quickly go into liver failure and cerebral edema. So in putting it all together, if you're going to evaluate the liver by labs, you need to look at hepatocyte integrity with AST and ALT. You need to think about bile flow versus bile duct versus bilirubin. Certainly need to think about synthetic function, and at least think about toxin removal, and is that impaired. And then once you have that, you can make a much better stab at that etiology. So evaluate the whole liver before you start sending off tests for etiology. Thank you.